Well, welcome everyone to this very first Tinnitus Quest live event. I should say our first public live event because we did already have a live event for researchers only, where 18 researchers presented their ideas on how tinnitus could be silenced. And most of them have given us permission to publish those talks. So you'll see some publications from us on that coming up. But this is the very first public live event where anyone can attend. The first, in fact, of a series of events where we feature the researchers who are part of Tinnitus Quest's board and have them answer questions about their own research and also how they think tinnitus can be silenced. Dr. Hamid Jalilian is today the first of our researchers to be featured in this Q&A session. After Hamid, we will have Bertolt Langut and Dirk de Ridder do a similar Q&A session. And we will also organize an Ask Us Anything event where the whole Tinnitus Quest board will be represented to answer a broad range of questions on funding, research, communication, really anything you would like to know from us. In a few days, we will open up registration for all of these events. So please come back and check on our website in a few days on the homepage under timeline. You will already now find the dates for all of these future live events. And in a few days, we will also add the register now buttons where you can register for these events. I want to say just a few words on why we are doing these live events. When Sven Goldman initially approached us with this new initiative that is now called Tinnitus Quest, he was very clear that one of the basic values of this new organization should be transparency and frequent communication about research to really bring the patient community and researchers closer together. And we wholeheartedly agreed with that principle. Marco and I had been co-running Tinnitus Hub, our other nonprofit, for many years together at that point. And we were always asking researchers to communicate more, and it was often hard to get information from them. But now with Tinnitus Quest, we will be giving out research grants. And one of the hard conditions of receiving such a grant will be quarterly communication updates on research progress, both the successes and the failures, because we believe you can also learn a lot from failures. So this is why we're doing these live events, to set the tone for a change in the tinnitus research landscape, to become more open and more patient-driven. We call it the quiet revolution. In a few moments, Hamid will start off with a few slides to introduce his research, and then he will be answering your questions. The majority of time will be Q&A. Dr. Hamid Jalilian is a board-certified medical doctor and a professor of otolaryngology, neurosurgery, and biomedical engineering at University of California, Irvine. With over 300 articles published, Hamid conducts research related to hearing loss, dizziness, ear infections, migraine, and device and software development for treating tinnitus, in addition to a busy clinical practice. Hamid, I will hand over to you now and to the audience while Hamid goes through his presentation, which should only take 10 or 15 minutes. You can already start leaving your questions in the Q&A box. All of you have access to it. I see some questions were already left there. I will be moderating the questions and selecting some for Hamid to answer. We'll try to get through as many of them as we can, but probably we won't be able to cover all of them. I also have a list of 20 or so pre-submitted questions that we received from Tinnitus Talk and Reddit and some other places. And I'll try to get through some of those as well. So if you hear me asking questions that are not here in the Q&A box, that's why. Hamid, over to you.
Thank you very much, Hazel, for that kind introduction. And thank you, everyone, for coming. And good morning and good evening, wherever you are. So I'm just going to go over some of the recent work we have been doing on trying to solve tinnitus. So the first question is, what causes tinnitus? And sort of ultimately, what causes tinnitus is a loss of cells, excuse me, in the inner ear. Now, we started losing cells in the inner ear very early on. The hearing loss that we see on audiograms does not show up until much later because the cell loss that initially occurs is in ranges of hearing where we actually do not test. Um, and you can also lose many cells, up to about 30% at least, cells in a certain area of the inner ear or the cochlea without having any change to the audiogram. So a normal audiogram does not mean you have normal hearing and intact hearing cells. It just means that it's not enough to cause a change on the actual hearing test. So ultimately, that's what it's caused by. It's the loss of cells in the inner ear causes the brain cells that those cells are not dead, those cells are alive, but those cells have to find something else to do. And that something else that the brain cells do is they start doing other things. So this picture here on the right side of the slide, I don't know if you can see my mouse or not, but basically the top panel represents image of the brain of an animal that has an intact hearing. Now you can see that sort of it starts with white and it goes all the way to the sort of the darker color. Those are different regions of frequencies of hearing that brain of that animal has. But then when the some trauma was caused with noise and caused damage to certain areas of the hearing, the parts of the brain that used to do the job of the high pitches have now changed to other pitches. That has been found to increase the activity, the increase in the electrical activity of those cells, which is what the tinnitus is. So our attention to that sound, not sound, but that electric activity is interpreted as sound by the brain. So the brain says there is some electrical activity in the hearing part. That must mean that there is a sound around. So now that explains kind of the baseline ringing, buzzing, humming, hissing, whatever you may hear. The sound that you hear corresponds to the region of hearing loss. So a ringing and a hissing or high-pitched sounds, a buzzing and a humming or low-pitched sounds. And that's where you've lost hearing potentially. So let me see, let's go to the next slide. So now, is there more to the cause of this? And we believe there is, because why is it that some people have very loud tinnitus and some people don't? Why is it that some people have some days where it's really loud and some days where it's quiet? Or people have intermittent tinnitus, meaning they get tinnitus for a couple of days and then it goes away and then it comes back. That can't be explained with the previous studies that have been done on this. So there must be a second process that's leading to these three things that I just discussed. That second process in our sort of research we found is a phenomenon related to migraine. So we call this otologic migraine, which is a migraine that affects the ear. So if you think about migraine, everyone thinks of it as it being a headache problem. But there are people who get migraine and never get a headache. Those are things like ocular migraine. There is what's called abdominal migraine. These people are not headache sufferers. They have symptoms specific to those areas. And otologic migraine is just a different form of it. And if we control this second process, this migraine process or brain sensitivity process, then we can actually control the loudness of the tinnitus. And if we catch it early enough, when it's in the intermittent phase, we can actually completely stop the tinnitus. Now, how is migraine related to tinnitus? We actually did a study looking at a large database of a nationally representative population in the United States of close to 13,000 patients. And you can see that how many people had migraine, about 20% of them, and about 18% or so had a subjective hearing loss. And then 20% had kind of tinnitus of any duration. And what we found is that migraine is more common in people with tinnitus, and tinnitus is more common in patients with migraine. And when we look at it here, this is sort of the table. I have that little red box around it. You can see that people who have migraine or had a history of migraine, it is just the headache migraine, so not even including the kind of non-headache migraines. They were twice as more likely to have tinnitus of any duration. And in those who had constant duration, it was approximately about 70% higher chance. Now, this it wasn't just our study that's shown this. Other people have done this a similar study. Professor Longus, who is also on the board of Tinnitus Quest, has found that a lot higher percentage of patients with tinnitus suffer from migraine. And this is another professor from Taiwan who also did a large study, and they found that tinnitus is 3 times more common in people with migraine. So migraine is actually related to tinnitus, and not all migraine is headache related. So migraine is more than a headache issue. There are people who have migraine and they never get a headache in their life, as I mentioned, the ocular, etc. Migraine is really at its core a sensitivity of the brain. The brain becomes sensitive during the migraine, and that sensitivity can manifest itself as things like hyperacusis, meaning that you're sensitive to sound. It can be atmospheric pressure sensitivity, where people say when there is cloudy weather or windy weather, etc., or there's a storm coming, my tinnitus gets louder. That's because the migraine process is getting active. That then causes the brain to pay more attention to that signal, and that then makes you hear the tinnitus at a louder level. It's what creates visual motion sensitivity, where you're scrolling on your phone and might feel dizzy, or might sometimes. I've had patients where when they play video games, it makes their tinnitus louder. Motion sickness is part of that. People can get all sorts of other ear-related migraine symptoms, including vertigo, which is more than 95% of the time related to migraine, episodic imbalance, not constant imbalance, but episodic imbalance, sort of this generalized dizziness feeling, the feeling of stiffness or pain in the neck, a lot of TMJ-related problems in the absence of a jaw joint problem and the absence of an anatomic problem in the joint. People who have tension in the muscles around there, that is actually another form of migraine. You can get sinus pressure, which is a lot of times misinterpreted as being sinus infections. You can get facial pressure, pain, head pressure, and not the headache. You can get nasal congestion, even runny nose from migraine, because it causes dilation of blood vessels. So the brain gets sensitive in a migraine. That causes the tinnitus to be to sound louder to you. And basically, when the migraine's active, you get loud tinnitus. When the migraine's not active, the tinnitus is going to be quieter. So again, just to emphasize again, active migraine does not mean somebody has a headache. It just means that the brain has become sensitive. And the fluctuation in the tinnitus are really due to that activation of migraine. Now, who would benefit from this migraine treatment that we use? Or it's people who have fluctuating level of tinnitus. So one of the first questions we ask is, does your tinnitus go up and down in volume? And if it does, then we can get rid of the peaks of the tinnitus. We can't get rid of the baseline tinnitus because that baseline tinnitus is caused by the cell loss in the inner ear and the changes in the brain. That requires something else, and that's the next thing I will be talking about. People who have intermittent tinnitus, if we catch people very early on in the onset, we actually can really help them because I have multiple patients have been able to actually stop the tinnitus if we catch them very early before it's become sort of permanent, where the brain is continually paying attention to it. People who say that they used to have a quiet tinnitus and then suddenly their tinnitus got loud and it stayed loud. Those are, again, due to an activation of migraine. And then the so-called somatic tinnitus, which is where people can manipulate or put pressure on their head or jaw, and that causes a change in the tinnitus volume or in the pitch of the tinnitus. That's also another migraine-related phenomenon. There are 2 pathways that migraine can cause tinnitus. One is through the process that causes a change in the blood flow to the inner ear, and that can cause a tiny little bit of hearing loss, which can then cause a tinnitus temporarily, or it can create the brain sensitivity, which is the more common pathway that happens. Now, people say that, why is it that I have intermittent symptoms? And what I try to talk about is really there's this threshold in your brain, and that threshold is different in different people. And various factors such as stress, sleep, diet, hormonal changes, and whatnot will then cause that brain activity to increase. And once it reaches the threshold, then the migraine becomes fully active. And we get the changes in that so-called trigeminal nerve, the nerve that supplies the whole head and neck. And that then what makes the brain very sensitive and leads to the attention to the tinnitus. Now, that factor may go away, meaning it's something you ate and that goes out of your system after several hours. And then the tinnitus settles down. And then another couple of days later, you might get dehydrated and that then peaks it. And then you get tinnitus again, etc. Now, the goal is to get people to get back to where their baseline used to be before they started getting fluctuation in their tinnitus. And what I tell people is you're going to be able to eat all the same stuff again. It's just that temporarily we need to be a little bit strict on the diet until we can get you through this process. But it's not just diet. We have to fix the sleep, etc. And people say, well, I have constant loud tinnitus. How could this be a constant migraine? I've never heard of a constant migraine. Well, constant migraine does exist. It's called status migrainosus. And what it is basically if you're sustained level above that threshold, you will continue to have a migraine. And that could be maintained by things that are like you're doing every day, like diet and stress and sleep, etc. And there are different thresholds for migraine. So people can have a headache threshold and a tinnitus threshold, and those may be different. So you may have gotten headaches before, or you might get tinnitus at a later point. These are all different forms of the migraine. They might sort of present differently. And medications that we use are intended to elevate the threshold so that we can get you basically below the line. And we get below the line, then the tinnitus is going to sound quieter. So that's what the medication does is basically we're trying to get the brain activity below the threshold. Now we elevate the threshold with medicines. We lower that brain activity with lifestyle changes. Now, the first thing is we have to identify the triggers, and this is where a lot of time is spent talking to the patient, talking about sleep and stress and diet and addressing each of those separately. Hormonal changes and overstimulation are the 5 main triggers of migraine and thus loud tinnitus. Now, we have to do things like reducing the stress reaction, that's part of why we like to do cognitive behavioral therapy, the online cognitive behavioral therapy, because that part of that is teaching how people to react to stress. It's not intended to, to get used to the tinnitus, which I kind of hate that term, or you have to get used to it, or you have to live with it, because we can actually do something about tinnitus. It used to be there was no treatment available, but now there is. Now, we can't get rid of tinnitus, but we can make it quieter in those people who are very distressed by it. That's for sure. Now, we can improve, we have to improve sleep. We have to correct circadian rhythm disorder, which is the brain's 24-hour clock system is off a lot of times on patients with this problem. We have to optimize their diet and reduce hormonal fluctuations if we can. In some people where it's possible, men can get it from using testosterone, and women get it from just the natural hormonal changes, or sometimes from birth control pills. And then reduce overstimulation if there's particular things that they're sensitive to. And then we use the medications. As I said, we do use some supplements that have been found to be low in the blood or the brain fluids in people with chronic migraine. These are not the ones that you buy over the counter that are like the mixed ones that are, the various things like quietus and lipoflavonoids and things. None of those actually work, but these are targeted supplements that we do use, and they are actually they do work. Now, we do use sound and cognitive behavioral therapy because the cognitive behavioral therapy for us really targets migraine education. It has some tinnitus education, but really it's all about how migraine affects it. And it's just a lot more detail than somebody can provide in a visit with a patient. And has exercises on teaching people how to do meditation to reduce the stress reaction. Because you might get upset at something at work, you kind of steam over it for days, but nobody else even cares that actually happened. That steaming over it is what then maintains high stress, which maintains the migraine, which makes the tinnitus look. And a lot of the CBT is to teach people to not react negatively to everyday situations. Migraine and tinnitus are really complex disorders. They need kind of a multimodal medical solution. It's, there isn't, a magic pill. So, the medications we use, if we just use them and we just compare to people making the lifestyle changes, they're probably about equivalent. It's when we combine them together is when we get the really maximal effect. This is a recent study we did on a randomized clinical trial of medications used for the treatment of migraine and tinnitus. So the first group, it got nortriptyline and topiramate. Second group got verapamil paroxetine. And the third group, it was the control group, got the sugar pill. And basically above the line means they didn't get better or potentially got worse. Below the line means that they got better. And you can see the control group sort of is hovering the line. Some people on this side, some people on this side. And the drug groups, most of them are on the bottom, meaning most patients got better. And you can see the percentages. This is based on the tinnitus functional index. So we look at migraine as being a kind of a comprehensive issue that affects a lot of ear issues. You can see tinnitus, hyperacusis. It can cause hearing loss, sudden hearing loss, severe migraine, etc. Now, I'm going to shift gears because, as I said, this reduces the fluctuation of tinnitus, where our goal is to also silence the tinnitus completely. So we actually did a series of experiments looking at electric stimulation. So we tried different modes of stimulation. We first tried the scalp, and we even tried through the nose. We tried all sorts of different ways to see if we can target electric activity to get to the inner ear. And what we found that the closer you are, the better. So what we found is if you do a tympanic membrane or eardrum stimulation, you're much more likely to get silencing of the tinnitus. We couldn't get it on a lot of people, but it did work for some people. Now, what we thought is, hey, can we get closer than this? And so then, I'm sorry, let's show you this. This is basically the people who were stimulated on the eardrum. And if you're left of the zero, that means you had some percentage improvement. There was a good number of people who didn't have improvement, as I said, but there are some people who had a pretty significant improvement in volume of the tinnitus. Now, and this is the control group, and this is the ear canal group. So the ear canal stimulation didn't get us much. The control group, still some people have a placebo effect from, of course, doing nothing. So this is, we put an electrode, didn't stimulate them. So some people got a little bit better, some people got a lot better, but most people did not get better. So we thought, can we get closer to the inner ear? And so then what we did, the next experiment we did was we numbed up the eardrum, made a tiny little incision in the eardrum, and passed a little electrode. This is the electrode we used. This is kind of under the microscope. This is a little incision, and that's the electrode going through. Initially, I would actually have to hold that electrode in for an hour at a time, which is kind of very difficult to do because you have to hold it in a very precise position and not move even a millimeter. So then we actually built this contraption to hold the electrode in so that we could do the experiments a little bit longer. This is my colleague Fang Gang Zhang in our department. We did 10 subjects. We tried 19 different stimulation patterns, and about 60% of them had a pretty significant suppression. I think one of the people we actually stimulated is actually in the audience right now, was sent a message here. But we had people where it went away for a couple hours. We had people who went away for a few minutes. So it works. It doesn't work in everybody, but at least it did seem to work then better than any other stimulation we tried. These are the different types of responses we got. So this is the tinnitus. This is the stimulus. The stimulus is the black line here on the bottom. This is like a T7, which is, we're starting at the very left. So the red line means the tinnitus didn't change on the first one. If you look at T8, there is a little short duration where it maybe changed a little bit, but it didn't really change. But on T10, you can see that it had a pretty significant drop. It went up again, and then it came down, and then it became zero. And on like T9, we had, as soon as the stimulus was turned on, the tinnitus went down to zero, but the patient actually heard a sound too. And T3, as we turned on the stimulation, they could hear the stimulation, but their tinnitus got better, and over time, they stopped hearing the stimulation also, so it became completely silent. So what we learned from that is if we can stimulate the inner ear, we can actually quiet the tinnitus completely. And so then this is without placing an electrode inside the inner ear. This is placed in what we call the middle ear, which is the space behind the eardrum. So now we've been working on a semi-implantable device. This device will have three components to it. There is an implantable chip, which is that tiny thing you see on the quarter, on the sort of coin on the bottom, that little square you see, that is the implantable chip that is going to be placed behind the eardrum. There's going to be some coils because the device inside is powered by an outside device. So all the battery and stuff is on the ear canal, and that sends the signal from a handheld device. So there's a handheld device. That's where the programming is done. That information goes to the ear canal device. The ear canal device sends that information along with basically energy to the internal implant, and the internal implant does the stimulation. And I think a lot of questions were, where are we with that device? Currently, the implanted portion, all the chip design and stuff has been completed. We're working on the sort of the shape of it so that we can fit it into the very small space behind the eardrum, because as you know, there's very little space there. We only have about a 4x4 millimeter space that we can place something in. And so this device is pretty tiny, but we also have to look at the width of the device, basically, so that it doesn't sit against the eardrum from the inside. And then we're trying different ways of the coils to see if we can put more coils outside versus inside, et cetera, to try to get more energy in without making the inside device too bulky. And this would require a very small procedure to place this. Somebody who does a lot of ear surgery could probably do this in the clinic. Somebody who doesn't do a lot of ear surgery would have to do this in a surgery center or something in the future. And that is all I have. And I'll be happy to answer any questions. And I hope I didn't go too much over time.
It's fine. I mean, thank you so much. So I'm kind of struggling here to figure out which questions to address first, because we're getting a lot, which is good. I was thinking maybe just to start a little bit with the pathophysiology of tinnitus, like really the basic mechanisms. And I know you addressed it a little bit, but for instance, we received this question: if hearing loss causes tinnitus, shouldn't everyone with hearing loss have tinnitus? There's also this one, whether the pathology of hearing loss matters to tinnitus. So could you talk a bit in general about the relationship between hearing loss and tinnitus and the pathophysiology of tinnitus in general?
That's a great question. The first question is exactly the same question that I had. Is, tinnitus and hearing loss we know are related, but not everyone with hearing loss gets tinnitus. And although I should tell you that everyone with tinnitus technically has some hearing loss, they may not realize they have it. They have hearing cell loss. So the question is, why is it that suddenly people start hearing the tinnitus? And we think that there may be a role in migraine in the initial onset of this too. And we're actually starting a clinical trial now. We just got approval, in fact, yesterday, to start this trial to treat patients with acute tinnitus. So in the first 3 months of the onset, to see how many people we can actually potentially silence, and how early in the onset do we have to get to the patient in order to do this. If we can actually find that, then and we can get other doctors to learn about it, which has always been a problem, because from something that's discovered until it's practiced by more than half the people, of half the physicians, takes about 17 years, which is crazy, but that's unfortunately the reality. So a lot of what we're trying to do is kind of educate not only the doctors, but also the patients, so they know to seek care. But if we can catch people early enough, we think that we can silence some people. That's why we're doing it, because we think there is a migraine component in the very early onset. Is that the only reason? I don't know, but we believe that's a big reason for a lot of people.
Okay. There was also a few questions actually about this, the connection between tinnitus and hyperacusis.
Yeah, that's a great question. Yes, there definitely is a connection between tinnitus and hyperacusis. So when you think about what migraine, as I said, is a brain sensitivity problem. So when you have brain sensitivity, you're paying more attention to the internal signal. That internal signal is that tinnitus signal, so it sounds louder. And your brain sensitivity is amplifying the external signal, the outside sound. So hyperacusis is basically sound from the outside sounding too loud to you. And tinnitus is internal sound sounding too loud to you, where you are hearing it at a louder level. So they're definitely connected, and they're connected through that migraine problem.
And another question about connections with other conditions is TMJ. You did mention it, and I believe you said it could also, in some cases, be a symptom of migraine. So, but is that the only connection, or are there other connections between TMJ and tinnitus?
Sure. Yeah. So thank you. That basically, yes, that is correct in that a lot of people who get diagnosed as having a TMJ disorder actually have and what we call an atypical migraine disorder, where they're getting, it's the same nerve that gives you a headache, is the same nerve that causes the brain sensitivity. It's the same nerve that causes the hearing loss and the dizziness from migraine. That same nerve goes to all the muscles around the TMJ. It supplies the muscles. So when that nerve gets very active, that causes a spasm of the muscles. So then it manifests itself as tightness of the jaw, and then a lot of doctors or dentists will diagnose this as a TMJ disorder. Now, there are people who have TMJ disorder to begin with, meaning that they actually have a joint problem, and that then causes tension of the muscles and pain, and that can then induce migraine. So they kind of feed onto each other in a kind of a positive feedback loop. So yes, they are related, but it's really through the migraine pathway. TMJ disorder can activate migraine. Migraine can masquerade as a TMJ disorder because it looks very similar in some people. And that same migraine process can make tinnitus louder. So people sometimes take medication for TMJ problems, and that actually is helping their migraine. And then their tinnitus gets better. But they think really it's because the TMJ made the tinnitus better, but it's really because the medicines that they took have an effect on that migraine process in the brain.
Another question, kind of basic pathophysiology questions about why do I hear this tinnitus sound, someone else hears another sound, or why do some people hear many sounds at once?
Yeah, that's a great question. So between people, it probably has to do with the areas of loss of hearing cells. So people who have, low pitch sound loss, they will get tinnitus in a low pitches, which is going to sound like a humming, which is usually a single frequency, or a buzzing, which is multiple frequencies. In the high pitch hearing loss group, which is the more common hearing loss, people get a hissing, which is a broad frequency, or a ringing, which is a single frequency. Now, why do some people have multiple tones at different times or at the same time? That's a great question, and I don't have a great answer for it yet. We think that there is probably more attention to certain areas of the brain's hearing area, but I really can't be sure. So I don't want to give you a definitive answer because that is a question for me myself, and I'm trying to figure it out. So if I do, I will definitely let people know.
Yeah, it's also good to acknowledge what we don't know yet. Different people have been asking about why does this or that make my tinnitus worse, right? So I think someone else asked about why does my tinnitus react to sound? This person is asking why it reacts to exercise. Other people probably have other triggers. Can you talk a bit about triggers in general?
Yes. Those are great questions. So remember we talked about the 5 triggers for migraine, which are stress, sleep, diet, hormonal changes, and the last one is overstimulation. Overstimulation can be in the form of sound, most commonly for tinnitus. So people are reactive to sound. The second is atmospheric pressure changes. But then there are people who are sensitive to these other things, and I'll mention them. Those include bright lights. Some people are sensitive to light. Some people are sensitive to motion or visual motion. So a lot of head motion or looking at things that move a lot, like the video game I was just talking about. Or people who say when they scroll a lot on their phone, that makes their tinnitus louder. Some people are sensitive to intense exercise. Now, some of it could be because some people who get overheated can actually have an increase in their tinnitus too, or migraine, basically, which causes the tinnitus to be loud. So what I generally recommend for my patients, who have especially something like this is number one, try not to go super intensely on the exercise. So try to like go at 100%. Try to go at a little lower percent in terms of the intensity. And then the other is to also make sure you drink lots of water because dehydration is a big trigger. And then the third is to sometimes this could be from lifting weights because when you lift weight, you kind of bear down. That increases the blood pressure in the head because it reduces the blood flow coming back down. And that increase in the pressure in the head actually can spike the migraine because it stretches the lining of the brain, the so-called dura. And that's where that nerve, the so-called trigeminal nerve, has all its branches goes through that, I shouldn't say all the branches, but the sort of the first branch covers that entire covering of the brain. So when it gets stretched, it stimulates that nerve and triggers the migraine.
Thank you. We have also a bunch of questions along that are more about the longer term, like evolution of one's tinnitus, and if it gets if it stays mild for most people or gets worse over time. Some people are also asking if why somatosensory tinnitus worsens over time. I'm not sure if that's generally the case or not, but so in general, questions about both the prevalence and the evolution of tinnitus over time. What can you say about that?
So, just to kind of back up, if you take, what they've done studies on usually undergraduates who are at a university and have very good hearing and don't have tinnitus. And they've actually placed earplugs in them for a week. And half of them got tinnitus because if you just block external sound, your brain starts paying attention to the internal sound and you start hearing it. So that sound is there all the time, probably. And so there are a lot of people who have that sound. It's just a lot of times they don't necessarily pay attention to it. It's when the brain's attention to it increases is when it becomes very loud and intrusive. Now, it's true that a lot of people will have a mild tinnitus because, as I said, a lot of people have it, but don't pay attention to it. But then it can suddenly go up in volume due to the activation of the migraine process. That can happen due to things like hormonal changes. It could be due to sleep problems, stress, etc. And so a lot of what we try to do is figure out what the cause is and how to fix it.
I'm going to get back to one more question on sort of the pathophysiology stuff, but I think then we'll really move more to the, practical aspects of treatment. But I did think this one was interesting, the link. And maybe you can give a bit of background here because not everyone might know what GABA and glutamate are.
Sure. GABA and glutamate are basically hormones in the brain. Glutamate is very much involved in migraine. And one of the things we actually recommend as part of the treatment for the sort of migrainous tinnitus, which is as I said, the fluctuating, intermittent, etc. tinnitus or loud, bothersome tinnitus, is a low glutamate diet. Glutamate is in foods that are savory and prepackaged, ready to eat. These would be things like chips and frozen foods and canned foods and things like that. Comes in the form of MSG or monosodium glutamate. So glutamate is very much involved. GABA is kind of an inhibitory thing, and so the medication called gabapentin or Neurontin actually sort of increases that, or it acts on the receptor of GABA, and can actually help some people. So we do use GABA pentin to treat patients with this migraine. It's sort of probably maybe the third or fourth drug we try because there are some other drugs that we found to work better. And so we start with other things. It all depends. Every patient's different, but if somebody has a particular issue and we feel gabapentin helps them, we'll use gabapentin first line. But usually we try. Oftentimes we have to try a combination of a couple of meds to get the best effect. As I said, it requires a multimodal treatment. It's not one pill isn't going to solve the problem. We have to do the lifestyle changes, and oftentimes couple meds, one of which stimulates the GABA receptor in the brain.
Great. So let's go a bit more into the practicalities of treatment. So the first question is that you talk about an 85 to 90% success rate for your migraine protocol. Can you tell us what are those rates based on? And I will actually ask a follow-up question myself, which is I assume there's some kind of pre-selection where you're screening out people that you think are not suitable for this treatment. Therefore, you're selecting the people that you think will be more receptive to the treatment.
Definitely, yes. So that was actually a great point that you made, Hazel. And I will mention this in a second because it took us years to figure out who is going to benefit the most. And we saw it finally in our clinical trial that we just finished a few months ago. That's sort of the paper's under review from the journal. So we're just waiting to hear from them. But we found that the fluctuating tinnitus, the intermittent tinnitus, the ones whose baseline changed suddenly, and the somatic tinnitus, those are the ones that are eligible to be treated with our protocol. Somebody who says, I've had 30 years of loud tinnitus, and it's the same level all the time, that person is not going to benefit from the treatment. So we wouldn't offer them the treatment even. And so sometimes what we actually try to do is just try to screen people before we enroll them into the treatment. Is so just make sure that they're going to get benefit, because if, or people say, I have, they call it fluctuating tinnitus, but it's, they say, well, when it's super quiet, I hear it. And when it's not quiet, I don't hear it. That's not really fluctuating tinnitus. It's just because you're getting environmental, what we call masking. And so you're not hearing it. So that's really not a fluctuating tinnitus. Fluctuating tinnitus is people say, I wake up in the morning or, suddenly at 10 a.m., my tinnitus goes way loud and it's loud for the whole day. And then I go to bed and then, I wake up in the next morning and it's quiet. That's fluctuating. And then the next day, it's like a 3 and then suddenly it goes to a 7. That's fluctuating tinnitus. So yes, we do pre-select. Now, when we have pretty much every other migraine-related condition of the ear that we've treated, including the dizziness stuff and the hyperacusis and tinnitus, our studies have landed in that range. So one we got 87, one we got 88%, got better. So it just that's why the range exists, is because and some of it has to do just with the number of people who got enrolled, so that you couldn't get an 88%, if you had a percentage of it. So that's the range. It's based on just a lot of patients that were one of the problems I should tell you in general for tinnitus, because for us to do these studies, for other doctors to adopt this treatment, we have to do randomized controlled trials, meaning that we have to do a trial where some group gets a kind of a sham treatment or a placebo. They get a pill that doesn't have the medicine. The problem is there is no control for changing their sleep and for changing their diet. We can't put all of that into a single protocol of a clinical trial. Each of those has to be done separately. But a lot of this comes from just the sheer number of patients we've treated over the last probably 5-6 years or so with this regimen, and perfecting the regimen over time and finding who is going to benefit the most and looking at the ones that were most eligible for treatment and who got better.
And so the 90%, was that based on what outcome measure were you using there? Were you using the typical tinnitus functional index type of surveys or something else?
Yes, correct. I'm sorry. Yeah, tinnitus functional index and the what we call a visual analog scale, meaning of 0 to 10, how loud has your tinnitus been on average in the last week? Now, we've actually, for our new trial that we're doing, we're specifically looking at the good days and bad days separately, because I think we need to, because some people, when they average it out, it's sort of, we miss the this some of the spike activity. Somebody gets a spike only once a week versus someone gets a spike 4 days a week. The spikes matter, and so we're going to actually measure the spikes, the frequency, the kind of amplitude, how bad it is, and then all that separately. So as I said, we've learned so much by doing these trials and treating a lot of patients. So now we know how to measure it even better than we have been in the past.
I think that's a great improvement to just having someone take like a TFI survey. It's a moment in time, right? I could feel differently tomorrow or differently than yesterday. What you're describing is, and I've been saying this actually to researchers for many years, is that the variability also matters a lot, and people care a lot. Like they don't want to experience that constant like fluctuation and not knowing if they're going to have a good day or bad day. So tracking and measuring that, I think, is a great improvement to just doing like TFI.
Yeah, and TFI, does have some good information, and we're actually working on a new version of the TFI. But the first couple of questions on the TFI have, how loud over the last week, how loud has it been? What percentage of the time have you been aware of it and annoyed by it, et cetera? Those are 3 different questions. So it does have some of the sort of granular data we need also. But unfortunately, there's no perfect questionnaire. I think there is another questionnaire the Iowa group is developing, and we're developing our own questionnaire as well. Go ahead, please. Next one.
Yes, a number of people have asked about how to get treatment if you also have hyperacusis, or in the case of this person, pain hyperacusis.
Yeah. So hyperacusis and tinnitus in general, we treat it the same as the fluctuating tinnitus, because it is that migraine process which is causing the hyperacusis and causes the tinnitus to be loud. So fixing the migraine process will fix both of these things. Now, we don't necessarily use sound therapy for people with hyperacusis, especially the pain hyperacusis. And we do encourage people to reduce their avoidance behavior, because there's some, I have patients who come in, with earplugs and earmuffs, and what I try to encourage people is, when you're in a controlled environment, it's better to actually get a little bit exposure to sound. When you're in uncontrolled environment, like you're out in the street walking in the street, then wear your earplugs and stuff like that, because you don't know if a car is going to honk their horn. But if you're inside the house where you have control over your environment, it's better to be getting some ambient sound, because that helps quiet down the brain cells, which are creating the tinnitus perception to begin with. So it is a little bit more challenging, especially for the pain hyperacusis. But the pain happens as a result of a kind of a spasm of this so-called tensor tympani muscle, which is behind the eardrum, which is the nerve that supplies that muscle, is the same nerve that causes migraine, the trigeminal nerve. So the so-called tensor tympani syndrome that people, I saw some questions about, that's also a phenomenon related to migraine, and we treat it just like we treat migraine.
A number of people have asked about the names of medications, and maybe we need a disclaimer here that they shouldn't start randomly taking those, but
Yes.
if you could remind us of those.
Sure. Yeah. So there, the medications, there are a lot of migraine medicines. So there are, I think, like 9 classes of medicines that we use, and there are at least 3 to 4 medicines in each class that we use. So the list is quite long. It includes all the newer drugs, so like the injectable ones, and the ones like Nurtec, and there are some very old drugs like nortriptyline and things like that. So it all depends on the patient's issues. So if somebody has difficulty sleeping, or they have anxiety, et cetera, we will have to, if they take certain medications, if they take heart medicines, we have to change it. So a lot of it is dependent on the actual patient. So we don't have like a kind of one protocol that we can use for everyone, because everyone's different. I mean, everyone's got different needs. someone has glaucoma, there are a couple of medicines we can't use for that, So we ask a lot of those questions to try to figure out what we could use that's not going to interfere with everything else in their life. Um, you know, so, and then we have to play around the side effects because people with migraine tend to be very sensitive to medications. So we have to start them at very low doses. And we kind of slowly go up in the dose until we find the dose that works. Usually we keep them there for a few months and then we take them off. A lot of times we have to combine 2 meds, sometimes 3 meds to kind of get this reduced. But lifestyle changes is a main sort of thing that has to be done in addition to the medications for it to work. So, if I say, nortriptyline or, Paxil, et cetera, and you just go to your doctor and take it, most likely you're actually not going to get better with just taking the medicine because you got to do all the other stuff. Because as I said, migraine is a complex condition. We got to get rid of the triggers. Just taking a pill isn't going to fix the problem.
Before I go to the next question, just a quick matter of housekeeping. We had initially advertised this event to be 1 hour, but Dr. Jalilian is happy to stay up to 90 minutes. So we'll probably go over time and see if we can address as many questions as possible. And another thing is a few people have asked if this is being recorded and if we'll publish the recording, and the answer to that is yes. So you can watch the presentation back and if you missed anything. So we've gotten a bunch of questions, and we'll stay on the migraine protocol for a little bit and maybe then go to the electrical stimulation treatment. But on the migraine stuff, like a bunch of people have asked, how can I get access to it? Some are in the US, but they're far away from you. So where do they go? Some are in Europe. I think someone said, I'm in Belgium. Where do I get this? So what would you advise those people?
So this actually, is a problem I sort of faced because there were a lot of people who wanted to come see me after we kind of made these discoveries and published our papers and stuff. The problem is, at least in the United States, is we're limited by the so-called state licensing. So meaning that I can only see patients who are in California. I can't see somebody outside of California other than like a second opinion. So I can see them as a second opinion, but I can't treat them. So basically, what I did was I started partnering with a telemedicine clinic where they have practitioners who are licensed in multiple states, and they can then treat the patient. So I actually taught them how to do the treatment, and so then they can actually do this treatment for people across the country. I don't think they're in every state. I think they're in maybe 15 to 20 states, I believe. But that's how I've been doing it. And I know they've had patients from Europe, and they've had patients from the Middle East, and of course the United States.
Great. Let's see. Oh, maybe we'll take this one. I mean, it's kind of related. So I guess if you can't get access to treatment, is there something you can try on your own? And I would add the word safely.
Yeah, I mean, the best advice I can give you to do something on your own would be try to see if you can figure out what your trigger is. And most commonly, it's going to be stress and poor sleep. And if if you snore, you need to get a sleep study. If you have insomnia where you have trouble going to sleep, or you wake up in the middle of the night and you can't sleep, then you need to see a sleep therapist. They're basically psychologists who specialize in sleep, and they do an 8-week program called Cognitive Behavioral Therapy for Insomnia. So what's called circadian rhythm disorder, which is the brain's 24-hour clock system is a little bit off from 24 hours. So, the daylight hours, and how the clock is 24 hours, but the brain is just a little bit off from it. Now, you need to have a very strict routine of your sleep and your diet and stuff like that in order to kind of keep that brain clock set correctly. Now, if you actually are doing it incorrectly for a long time, it will just stay like that. So what the sleep therapist does is actually teaches you how to do it correctly, and tries to figure out what your sleep hours should be. So sometimes people say, I need my 8 hours of sleep. But the reality is their brain only needs 6 hours, and they're forcing their brain to sleep more. And that increase in the sleep that they're doing actually can trigger the migraine. So meaning that too much sleep is actually a problem in some people. Most commonly, it's too little sleep or an interrupted sleep. If you have problems with, let's say, a bladder issue that makes you get up to go to the bathroom multiple times a night, then you need to get that addressed. So that a lot of the stuff that I do for my patients is figure out what's causing their sleep issue and how we can fix it. If it's insomnia, they see a sleep therapist. If it's sleep apnea, they got to get a sleep study and get that treated. If it's a bladder issue, they got to do this. If it's their dog wakes them up, then, figure out how to do something about the dog. Because if your sleep's going to get interrupted every night because your dog's barking, then fix that problem, because good sleep is going to reduce the loudness of the tinnitus.
So I think we'll move to the electrical stimulation device, and I have some questions pre-submitted that I'll start with. So I cannot pull them up on the screen, but there was an intriguing question, and it was a whole discussion on the Tinnitus Talk forum yesterday, which is that actually this kind of technology apparently has been around for a long time, many decades, if I understand correctly. We've known that electrical stimulation of the inner ear can suppress tinnitus. So the question is, why did it take so long for this technology to sort of come to the stage where you are now? And I think there are actually several other projects in different parts of the world that are working on similar technology, and they're sort of, it's more advanced now than it has ever been. But, why did it take so long to get here, essentially?
That's a great question. I mean, when I started at University of California, Irvine, it was 2006, and I went to my colleague, Dr. Zhang, at the time, and I said, "Hey, we know cochlear implants can help with tinnitus at least 70% of the time, and why don't we just stimulate people from the outside? And we could do the same probably. At least we should test it." And the reality is, the main problem we have is money. I mean, and I think that's why really Tinnitus Quest is really doing what's necessary to kind of close that gap in funding, because the national funding agencies, at least in the United States, require a lot of what we call preliminary data in order to approve a grant, meaning that a lot of times you have to have done almost half the project, and then they will actually fund sort of the rest of it. And it just took a long time for us to get a small amount of initial funding so we could actually do some experiments. And then we then wrote a grant and were able to actually get some funding. But then for us to do the next stage, which is to build a device, we couldn't do it without a significant amount of funding. And again, the national funding agencies here, they don't give you money to build a new device that they're not sure is going to work necessarily. So they want preliminary data to show that this device has been built and it works, and they'll say, okay, we'll give you more money to get sort of the next stage. And that's where one of my patients, Brian Fargo, that you've interviewed as well, he stepped in and he said, I'm going to do something about this problem. And so he gave us the initial funding to get the project off the ground. And then we were able to raise some more funding to try to get us to the stage where we can hopefully get this in people as experimentally. And our goal is by sort of the end of next year to 2025. And that we hopefully we can then get some more funding to take us to do a full trial. And then that would then most likely would have to actually then leave the university, go into a private company that has to raise larger amounts of money to do a larger scale study across multiple sites in order to get the approval from at least the FDA in the United States, and then get the CE mark in Europe. So the key milestones that we have reached so far is we have designed the handheld part and the software for that. we have designed and for the most part completed the internal part, although we still have to do the packaging of the device. And that's what in an hour, I'm actually meeting with my team to talk about the exact dimensions of the packaging and stuff. We have to kind of get the coils sort of perfected so that we can ideally have a lower profile device on the inside. And then the external portion is in the process of being built, but the external portion is mostly off the shelf material. So we actually are having a private company build that for us so they can do it much faster. So that's where we're at with that project.
Yeah, and then you talked a bit about funding, and in this question, it's also asked, and a question that of course came up several times, and I can't even find an example now because we have like 80 questions in the chat, so it's becoming hard to find things. But there were obviously several questions about outlook, timeline, can you predict when, etc. So if you could go into the funding a bit more and the outlook as well.
Sure. And it's a good question in terms of how much money will it take to, get this to market. I can tell you that how much money will get to complete a clinical trial is probably in the, single-digit million dollar. For it to get to market, because this, is going to require a larger scale study. That's going to be, at least a double-digit $1 million, and that would have to be done, as I said, outside of a research funding. That would have to be done by a company that can raise money on either venture capital or something to kind of take it to the next stage. The solution for many of the world's problems is money. But at least in this problem, some of it is, the technological thing we have to overcome, which is that charging a device at that smallest scale had sort of never been done. And we've actually shown, at least in the lab, that it's doable with the size requirements that we have. We're just trying to get the device packaged and sizable enough so that it can fit inside the ear, sort of our next stage.
And I think this question is related, obviously, but if you could go into a bit more detail on what still needs to be scoped out in those future studies.
Yes. So basically, if our feasibility study looks good, and that would probably spill into most likely 2026 to be sort of realistic, and because we have to do some follow-up, we can't just put them in people and have the result. And then the phase 2 will have to be a larger scale study. We would have to go through the FDA to get all of the guidance we need in terms of what they will specifically need from us in terms of data in order to get FDA approval for this. Because we don't want to go through the whole study and then they say, oh, you should have done this thing, and then have to redo the whole thing. So that will be the FDA process will take a little bit of time. And then in addition, we would probably have to enroll, in a triple-digit number of patients. It all depends on what the FDA requires, but it will definitely be more than 100 and probably in the couple hundred people. So that we will get there, and when it will get to market, realistically, I don't really know. It all depends on how quickly we can get through the FDA and how quickly we can, have someone who picks it up and raises the enough money to bring an implantable device to market, which is a significant amount of money. I mean, this is going to be at least, $100 million, to get an implantable device into market. It takes a lot of money.
Yeah. Yeah. So a couple of people want to know if they can volunteer for trials at the moment or later, I guess.
Sure. The current trial that we have for tinnitus that's open is the acute tinnitus trial, which is less than 3 months of duration for tinnitus. The other trials that we have are kind of the medication one that was just for the chronic tinnitus. That one completed, and that's the one we figured out that actually the fluctuating patients did much better on. And then the electric stimulation and sound stimulation ones are on hold until we have our device built. So currently, if you have chronic tinnitus, we don't have one yet, but can you be on a list? Sure, we'd be happy to keep people on a list. So when the implantable device is available, we could contact people.
Yep. We got a couple of questions about how your device is similar or different to other devices. Obviously, there's the linear device on the market. There were a bunch of questions also about the Oracle device, which should be coming, who knows when, sometime in the next few years. So can you talk a bit about those devices and how they are similar or different in as far as you're aware?
So those devices combine some kind of electric stimulation and sound for to help with tinnitus, and the sound is and the electric stimulation are synchronized. So the linear device uses a tongue the paddle. It's sort of like a little spoon that's flat that you put on your tongue, and it kind of feels like this kind of like little like vibration, kind of almost like on the tongue. And you have the headphones on. You have to sit for 30 minutes twice a day to listen to the sound and to do the tongue stimulation. The what they say is that sort of at that time they don't want you to do kind of anything, but just to kind of relax. Um, you know, what I would like to see is if actually it's just somebody puts something in their mouth and just listens to sound and relaxes for an hour a day, how their tinnitus would be, because I suspect their tinnitus would get better because
There's a strong placebo effect you're
there
insinuating.
can be.
Yeah.
But now,
Yeah.
does linear do something? I think there are some people who really get benefit from it. I don't know. You know, uh, I can't sort of speak for their results, but I can say that there are people who really like it, and I've had a number of patients where they didn't get any benefit, but I'm going to get the patients who didn't get benefit because the ones who got better aren't going to come see me. So I have kind of a biased view of it because I don't see the ones who got better. So I think both devices, both the Oracle device and the linear device, use a similar idea. I think the Oracle device is intended for somatic tinnitus. I don't know what their FDA designation will be, if it will be just for somatic tinnitus, which is the ones where pressing on a part of your head or neck will change the tinnitus tone or loudness. So time will tell. I think these there's some people who are going to respond to one thing and some people are going to respond to another thing. I think there's probably merits to using something like this for the chronic non-fluctuating tinnitus. But the people who have fluctuating tinnitus, we really need to address the brain issue, which is that migraine process. Now, if we address that migraine process and their tinnitus doesn't have fluctuation, but it's still bothersome, then I think there's definitely they may benefit from one of these devices. I mean, the only issue with these devices, they're expensive, and there's sort of no way to kind of return them. If it doesn't work, so you have to just pay the money and hope for the best.
That actually begs the question. I'm not sure if anyone asked it. Probably they did. But if you have any idea of what the cost of the electrical stimulation treatment would be once it comes to market, I understand it's very hard to predict because you probably need a commercial company to come and pick it up and commercialize it, and they will be determining the price. And then, there's so many factors that go into it. But do you have any idea?
No idea. I mean, it does have three electronic components, one of which is implantable. If it can get the designation by the FDA that this treats tinnitus, which we believe it should, based on our electric stimulation experiments, then that would then get insurance coverage. The main problem has been, all these devices have gotten sort of the approval as a lot of times as in a way that insurances unfortunately do not cover them, and so that sort of time will tell what the price will be. But a lot of it depends on insurance coverage, of course.
Is the technology itself expensive and the implantation process, or Is it one of
Well,
those things where once you do it on scale, maybe you could make it cheaper, etc.?
yeah, of course. Yeah, I mean, they're definitely on scale. Everything does become cheaper, but implantable devices is certain type of processing. They have to be manufactured in certain facilities, and they have to be able to withstand all of the changes that happen in the kind of physiologic fluids of the ear, and the pressure changes and all that other stuff that happens. So, and there is more liability, for a company that makes an implantable device. So they have to have, be able to recover. It's, part of the reason cochlear implants are so expensive because, if there is a problem, it costs millions of dollars to sort of clean up the problem.
Yeah. Yeah, fair enough. This question is interesting. Does the implant need to be customized to the individual?
No, that's the sort of the way we've designed it is that the customization is done in the handheld device. So everything else is going to be, everyone gets the same size device. The handheld device will be the same for everyone. It's just the software will be programmed a little bit differently for each person.
Okay, I got a bunch of pre-submitted questions that are about kind of who are the suitable candidates for this type of treatment, right? So, is it if I have Meniere's disease, if I have hyperacusis, if I have severe hearing loss, like is who is most suitable for this?
For the implantable device, when we actually first did our trial, we initially started with people with sort of moderately severe or severe loss because we weren't sure if it's going to cause hearing loss. So we wanted to be really sure that we're not going to damage anything when we electrically stimulate the ear. We didn't think it would, but just to be safe, we always have to kind of be, do the best for the patient. So we picked people where their hearing was kind of unusable, and then stimulated them, and those people actually did well. And one of which actually did, we did 5 minutes of stimulation. We got about 4 or 5 hours of sort of silence of the tinnitus. So then that made us think that this is actually probably safe. We tested their hearing before and after and whatnot and found that there's no damage. And so then we started doing people with normal hearing. Some of the patients we tested did have Meniere's disease history. Um, and I'm just trying to think what the other question was about. You said Meniere's disease. What other conditions?
Hyperacusis, reactive tinnitus.
Got it. I mean, if somebody comes in with reactive tinnitus or hyperacusis, we will first treat their migraine, the migraine process, because that's what's driving the reactive tinnitus and the hyperacusis. And if we treat that and they don't get better, or we can take away the spikes, then we would do something like electric stimulation potentially.
Okay. So I thought this was a really nice question, and how can researchers work together better, and particularly when they're working on similar technology, and how can Tinnitus Quest help with that? We did mention briefly that there are similar research projects to yours in other places. I think there's one in Germany and one other one that I forget. So maybe you can also relate it to that a little bit.
Yeah. So I think one of the challenges is going to be because each person has a different take on how to do it. So there's another group that's using a device that looks very much like a cochlear implant. So you have to make an incision in the back, place the device under the scalp. You have to then remove some bone from the back of the ear, kind of go between the two little nerves, so the facial nerve and the taste nerve, and then put the electrode right next to the cochlea. And I have no doubt that device actually will work because our device works, at least or I shouldn't say our device, but our technology of electric stimulation works. So I know that it will work. It's just that how many surgeons are there who can place that device? And at least in the United States, there are probably only about 300 to 400 people who can do that surgery because that's a very highly technical surgery. Now, I thought, I'd actually thought about a device like that. And I just thought, if I bring a device, go through all this work, get a device to market that only 300, 400 people can actually put in people. And, there are millions of people who suffer from tinnitus. And there are only a couple hundred people who can actually do the surgery. There's no way they could actually help a lot of people. So my concept was, can I make this device so easy and simple to place that a general ear, nose, and throat doctor, of which there are, at least in the United States, there are like 7,000 to 8,000 of them, can actually place. In which case, then the ability for patients to access the care is a lot better. So that's why we went about doing ours a little differently. And as I said, I'm sure the device that Dr. Carlson, I believe in Berlin, I believe it's in Berlin, they're working on, is going to work. It's just that, how many people would be able to access that? I think if it requires a big surgery that's highly technical, not many people are going to be able to get it, because all these other surgeons are doing other things at the same time. It's not like, I do 6 surgeries a week for non-tinnitus related stuff. My ability to then add that on top of my practice is limited. But if I can make something that any general ENT can place, then I can hopefully help more people. That's sort of ultimately my goal.
That makes sense, and I think it would be difficult to collaborate once you're this far down the road, right? The moment to collaborate is before you start something. And I think that's to address the question about how Tinnitus Quest can help. I think that's one of the things we'll be looking at when we give grads, is to ensure, if someone else is working on a similar thing, let's connect them, let's get the collaboration started from the beginning. And I guess also just looking at, because we'll be funding new treatment approaches, new treatment ideas, but I guess from the beginning we'll have to look at, think of the commercialization aspect as well, and make sure that the way it's designed or conceived of from the beginning it's as easy as possible to get it to market quickly. But I'm just thinking out loud here, guys, because we haven't even really set up the funding, the requirements yet. So, maybe then a technical question. If the electrical stimulation reaches the DCN, that's the dorsal cochlear nucleus, and I think the reason that question is being asked is also because of the Oracle device, which, the theory behind that is specifically related to the DCN.
So, electric stimulation of the cochlea, just to kind of, the reason this works is because when you lose hearing cells, you actually lose the so-called hair cells. Those are the ones that have the little microscopic hairs that pick up the vibration of the liquids of the inner ear. You don't lose the nerve cells, the neurons that actually send that electric signal to the brain. Those neurons stay around for probably at least we know 15 to 20 years afterwards. You start losing some slowly, but you maintain a bunch of them. Excuse me. And the concept behind our device and any electric stimulation of the ear is that you can stimulate those neurons electrically, even though they're not connected to any kind of hearing cells. So, and as the electric signal goes through the nerve, it goes through the dorsal cochlear nucleus. So any electric stimulation of the ear is going to go through there. Now, does the electric stimulation of the neck in the Oracle device, does that actually go through the dorsal cochlear nucleus? I don't know. The sound does. So if you're doing sound stimulation, you will definitely get, stimulation in the nucleus and the brainstem. So, yes, our electric stimulation for sure will get through the dorsal, because it has to go through there to get to the brain. There is no other way for it to get to the brain.
Hamid, as we're sort of nearing the end, I don't know if there were any questions that you saw that you specifically wanted to address, or just in general topics that you want to follow up on.
I'm just looking quickly through the questions to see.
Yeah, there are 80 now, so it's a lot.
Yeah.
But take a minute, if you will, to see if there's any you want to pick out.
me just go to the bottom because I think we've gotten a lot of the early ones. Yeah. So one of the questions is, can your forthcoming papers affect the way clinicians in other countries practice? And so, for example, they're saying in the United Kingdom that people just follow the NICE, the NICE guidelines, and they say no medication is prescribed for tinnitus. And I think this is uh, sometimes the patients kind of have to empower themselves and find the papers and take it to their clinicians and say, hey, these people have done this. Can you do the same thing? And if you can't get traction, that's part of the reason I work with that telemedicine clinic, is to then be able to help people who can't get help locally where they're at. Um, Somebody asked the name of the telehealth clinic. It doesn't have a commercial thing. I'm not going to mention it. You can just look it up. Um, yeah, what is the cost of the migraine treatment? Is it covered by insurance? So yeah, cost of the migraine treatment, if it's provided by a clinician, then that is covered by your insurance, because these are mostly generic drugs. They're actually very inexpensive. Even if you actually have to pay out of pocket, they're no more than $10 or $20 a month, at least in the United States, and probably less expensive outside the United States. And so, are you concerned about migraine medications being potentially ototoxic? Not at all, because none of the migraine medicines are ototoxic. Somebody asked about the funding requirements. 100 million seems very large, but for an implantable device, it's a lot bigger of a deal than a non-implantable device. That's why. And this would have to be through, either venture capital or, sort of the capital markets of, investment banks and whatnot. So this is not something that like Tinnitus Quest can fund, or any individual can fund.
Yeah.
I create a sort of electric shock with.
Yeah, I'm not sure about the goosebump question.
Yeah. Let's see here. Will this be available? Yeah, this is recorded, so you can watch the rest of it.
Yes, absolutely. I'm going to pull up this question. I mean, it's a very general one, and I think it might be a nice one to end on, if you could share your thoughts about why is tinnitus, has not been seen as a serious enough problem to warrant attention from governments, from the medical establishment, from funders, etc.
I mean, part of the problem, I think, is it's a silent disorder, because and if people don't experience it, they don't realize how severe it can affect people. I think that's probably one of the biggest issues. If some of the politicians had severe tinnitus, that there would be a lot more funding going into it. And I think there is a need for advocacy at sort of in the political advocacy, meaning that as patients, being organized and contacting your members of representatives in whatever country you are, and saying, hey, this is a big problem. And at least in the United States, people who are in sort of the Congress, they look at how many calls they get about a certain topic. And if they're getting, one person calls and says, why isn't there more funding for tinnitus? Then they say only one person cares about this. But if they get 100 calls about it, they say, this obviously is a problem. We need to do something about it. And if that is then multiplied by multiple people in Congress, then then that's going to be something that will then get amplified. So um, I just I think it's a lot of it is advocacy. I think a lot of it is because uh, is it the medical establishment that's causing the problem? I think a lot of people in the medical establishment, be it sort of physicians or whatever, are not necessarily all aware of this problem, and the problem has to generally be managed either by an ENT, and ENTs are trained to be surgeons, and so they like to deal with surgical problems. And if it's a medical problem, and especially if they don't understand what's causing it, they don't know what to do, and so they don't want to see the patient because they say that I don't know what to do, and there's nothing to be done, and you kind of have to live with it. And that then causes a lot more despair for the patient because they think that there's nothing that can be done. I mean, fortunately, now we have found ways of treating severe tinnitus and hyperacusis. And in fact, we at least I know the telemedicine clinic is just dealing primarily with severe fluctuating tinnitus, with or without hyperacusis, because those are the people who are going to get the most benefit, and going to really, we can make a difference. Now, what the treatment does, it gives them control. It takes away this sense that, am I going to have a bad day? Is it going to be a miserable day? And I don't know how long this is going to be loud. That's the goal. I think there are people who care. I mean, I definitely care. I definitely wouldn't lose hope, but it takes time for new treatments to be implemented by most clinicians, and you have to kind of sometimes advocate for yourself, and seek out treatment where you can get it. And if your provider doesn't provide it, then there are other ways you can receive the treatment for sure.
I said that was going to be the last question. It would have been a nice note to end on, but I do think this last minute question we received is, I think we haven't addressed that as far as I remember.
Sure, that's a great. So adverse event, and I don't know which trial they're talking about, but at least
the electrical.
Yeah, the electric stimulation we didn't. The only thing we did have, which nobody had ever actually talked about electric stimulation side effects, is there. People sometimes feel the stimulation in the ear, and sometimes people will hear the sound from the stimulation, because the stimulation is enough information goes up to the brain that they actually hear it. It tended to be that they actually got used to it. I'm just trying to think. There's a condition called otosclerosis. We had one patient who had that. And otosclerosis makes the bone very vascular, so the electric current spreads in the bone. So then that ended up causing stimulation of other nerves behind the ear. And so that patient, we couldn't help because we couldn't turn down the stimulation enough to give him tinnitus improvement without the current spreading. So, if somebody has otosclerosis, they're probably not going to be a great candidate for this because of the nature of their inner ear or cochlear bone.
Well, I'm going to end with this one. It's not a question, but I saw several comments along these lines. So I think this was very, very educational. And I want to thank you so much, Hamid, for spending 90 minutes with us. I will also note we started with, I think, 71 people and we still have 62. So I will tell you that's not typical for a 90-minute webinar. So I think people were interested. If you're listening and we didn't get to your question, I'm so sorry. Do feel free to email us at info@tinnitusquest.com, and we'll see if we can still get back to you. Hamid, do you have any final words or thoughts to share?
No, the only thing I like to sort of tell my own patients is, don't think that there's nothing that can be done. There's something, at least right now, there are things we can do to reduce the volume and to make it more tolerable. And silence will come. It's just a matter of time. It may be our device, it may be someone else's device, or maybe 3 devices on the market that do the same thing. And, you get to choose which one you want. But there will be a solution that's going to solve this problem. That I can guarantee you, because there are people like me who are determined to solve this, and have spent a lot of their lives and looking at this and trying to come up with a solution. And that's part of the role of Tinnitus Quest is to enable the people with sort of the new great ideas to have the funding to take these projects to the next stage. And I'm very fortunate to be on the board with some great clinician researchers like Dr. Longus and Professor de Ridder. And I think Professor de Ridder has put together a very good scientific advisory committee. And I think, you just need smart people working together and giving them the resources they need to carry out their ideas. And I think tinnitus will be solved, to be completely silenced. It's just a matter of time.
I think that's a great and very optimistic note to end on. Thank you so much for your time, Hamid. And I will now end this event, but I want to thank the audience so much for your active participation, and we hope to see you at the next event.
Great. Thank you again.
Bye, everyone.
Thanks. Bye-bye.
Bye.